For the sake of time, we'll get started. My name is James Kim. I'm at UT Southwestern in Dallas. It's about 5 hours north of here in this great state of Texas. We're going to be going over the lower extremity and just kind of very basic blocks. The design of this is to really spend as much time with a live scanning and to open up questions for anyone who may have any. And so please treat this like a free-for-all, like in the middle of my talk or in the middle of Dr. Burnett's scanning. If you have any questions, please just go ahead and raise your hand, or you can just say it out loud. I don't have any disclosures. I have the distinct pleasure of having Dr. Garrett Burnett here with us today, all the way from the Big Apple. He is the associate professor and associate program director of regional anesthesia acute pain medicine, their fellowship in the Department of Anesthesiology at Icahn School of Medicine at Mount Sinai. So Garrett and I have taught at multiple NYSORA workshops, and I thought he would be the perfect person to supplement this lecture. So it's really great to have you, Dr. Burnett. Very briefly, we'll be going over the anatomy of the lumbar and sacral plexus, an overview, some of the classical and contemporary approaches to blocks of the lower extremity, as well as discuss some indications and complications of some of these blocks, and then any current and future trends of any of the peripheral nerve blocks of the lower extremity. We know that the lumbar plexus comes off of L1 to L4, and the nerves that we're interested in for this lecture are going to be the femoral, the obturator, the lateral femoral cutaneous, and then we'll flip views to the sacral plexus around L4 to S3 as we cover the sciatic nerve. Just keep in mind that the lumbar plexus, as it does come off of L1 to L4, we are also getting the subcostal, the iliohypogastric, the ilioinguinal, and the genitofemoral. But again, for this lecture, we're going to cover the lower extremities, so we'll mainly focus on that femoral obturator and that lateral femoral cutaneous. This is just to remind us that when we're thinking about doing nerve blocks, to not only think about the dermatomes, but also osteotomes and myotomes. And the best example that I can think of for this is when we do a saphenous nerve block, we know that that sensory distribution comes off of the femoral nerve and gives you only that cutaneous distribution on the medial part of that leg. But we also know that the osteotomes of the tibia down there is innervated by the sciatic nerve. So just to kind of keep things in mind as we come up with a game plan for what nerves to block for which surgeries. Starting with the lumbar plexus block, the lumbar plexus itself, again, is formed by the ventral rami of L1 to L4. And these rami merge and form a plexus that travel just lateral to the the lumbar vertebra within the psoas muscle, which is why this block was historically called that psoas compartment block. The various branches of the plexus then emerge from the psoas muscle and continue down the anterior thigh to innervate their respective muscles. And again, there are the seven nerves that we talked about. In this view, you can see the patient is in lateral decubitus position. In terms of the markings, there is a line just above the iliac crest here, and about 2.5 to 3 centimeters lateral. You're going to place the curvilinear probe just a slightly medial angulation to look like this. And what you're going to see is a nice vertebral body, the transverse process. And then this is the psoas muscle here, and within the psoas muscle is where the lumbar plexus starts to rise and arborize into those different branches, the terminal branches of the femoral, the obturator, and the lateral femoral cutaneous. The various indications for the lumbar plexus block include hip surgery, any knee surgery above the knee amputations, great for that. Unfortunately, a lot of people have been veering away from this block because of the unwanted risks and complications associated with it, including bleeding, because as you saw from that initial picture, there's a lot going on there in the retroperitoneum, as well as big vascular structures. Local anesthetic injection into the dural sleeve can cause a high epidural or high spinal spread. And then the unilateral sympathectomy, while not as profound of a hypotensive response as you would see with an epidural or spinal, you could still have some unwanted hypotension. And then you are getting motor blockade because you're actually blocking the entire lumbar plexus. And so you just want to be careful if you're going to do a block that you're trying to avoid motor block or create motor sparing techniques. This would not be a block for it. And then not to mention, it is a deep, technically challenging block to do considering some of the other blocks that we have in mind. Some tips, if you are going to do this block, adhere to the ASRA anticoagulation guidelines for neuraxial technique, just to minimize the risk of hematoma. And then use ultrasound and nerve stimulator. You're trying to get that quad twitching at about 0.2 to 0.5 milliamps while you're also using the ultrasound. And then apply very low injection pressures once you're there, once you see that quad twitching, because high injection pressures have been associated with extravasation of that local anesthetic into the epidural space or into the dural sleeve to cause that high epidural, high spinal type picture. So with that in mind, do we have safer, easier approaches to kind of a lumbar plexus block by proxy? And the answer is yes. We have the fascial block. It has a safer profile and anesthetizes several key components of the lumbar plexus. The fascial is a wide sheet-like structure that lines the muscular bowl of the pelvis and overlies the iliacus and the psoas major muscles. And it continues underneath the inguinal ligament where it becomes continuous with the epimysium of the iliopsoas muscle itself. And we're interested in the three nerves in relation to the fascial iliaca. And again, those are going to be the femoral, the obturator, and the lateral femorocutaneous. So in this ultrasound image, you can see this is the classic infrainguinal approach where you're scanning just within the inguinal crease itself in a transverse view. You can see the femoral artery here, the femoral nerve just lies just lateral to that, and then the fascial iliaca runs this way and joins the epimysium of the iliopsoas down this way. And so that femoral nerve is within or underneath that fascial iliaca, sandwiched between that fascia as well as the iliopsoas muscle. And so our target would be way out here between the iliopsoas muscle and the sartorius muscle. So that was the infrainguinal approach. The problem with that is with the volumes that we're using, we're just not getting that much success in terms of getting the lateral femorocutaneous and the obturator. The majority of the time we're getting successful femoral nerve blockade with that. And so that's when we started to move up to the suprainguinal fascial iliaca to deposit more local into that pelvic brim. And this is a nice depiction. You may have heard of the bow tie sign, where the pinch of the bow tie here is just above the level of the anterior inferior iliac spine. And then the different leaves of the bow tie cranially would be the abdominal muscles, the internal oblique and the transversus abdominis, and then inferiorly by the sartorius. So I call this the dress to impress block. That's the bow tie if you ever hear of the bow tie sign. We know that with the fascial iliaca block, we are blocking those motor nerves. So then the question is, well, if we're going to do any motor sparing blocks, is there a different alternative? And then that's when the PENG block comes into play. So the PENG block stands for the pericapsular nerve group, named after Philip Peng, who discovered it. I'm still trying to find the Kim block, so if anyone has any good ideas, please let me know. What this does is it's really trying to get the really terminal branches off of the femoral, the obturator, and the accessory obturators. And so I just superimposed the muscles on top of the bony structures here. Here's the pelvic brim. You can see the AIIS over here, the iliopubic eminence. And in this trough here, right underneath the iliacus muscle and the psoas tendon, you have these terminal branches of your femoral nerve, your accessory obturator, and your obturator. And so when your needle comes down and touches down right on that trough of that pelvic brim, you get spread of local anesthetic that not only spreads medial laterally that you would see on the ultrasound because we're dealing with a 2D structure, but also cranial caudally along that pelvic brim, giving you nice coverage of those terminal branches. And this is what the ultrasound image would look like, where you have the AIIS over here on the lateral side, the iliopubic eminence on the medial side, the psoas tendon, and the iliacus muscle here. And when we do the live scanning, we'll show you just superficially, you would see the femoral artery and the nerve up there as well. And as the needle comes in this way, your target would be right in this area to bathe this trough to give you that nice spread of local anesthetic along that pelvic brim. When we look at some of the evidence behind PENG versus no block or PENG versus fascial block, the study on the left looked at 30 patients who underwent total hip arthroplasties, looking at PENG versus no block. And the primary outcomes were maximum pain scores as well as oral morphine equivalents, and the PENG group did much better in those two arenas. The study on the right looked also at patients undergoing primary total hips, looking at PENG blocks versus suprainguinal fascial blocks. They had very similar pain scores, similar oral morphine equivalents, but in the PENG group, they had less quadriceps and hip adductor muscle motor weakness. And so you can see why even some of our orthopedic colleagues prefer this block so that the patients can start to mobilize and do PT right in the PACU right away. Just tips when you're doing the PENG block, if the injection pressure feels very high, and a lot of times it does, it's a very tight space, slightly withdraw, less than a millimeter, because chances are the tip of your needle is wedged either into that psoas tendon or right along that osseous structure, and then inject as you pull back even a millimeter, and usually that helps to spread that local anesthetic without feeling that huge resistance. Hydrodissect with normal saline before you get to that spot. And the reason why I recommend this is if you do get some intramuscular spread while you're going in, sometimes that local can extravasate up to that femoral nerve and then cause quad weakness, which is the opposite of what we're trying to achieve here with this motor blockade. And then use dilute local anesthetic again for that same reason. 20 cc's is more than enough to cover all those terminal branches of those 3 nerves. So unlike the fascial block, the PENG block does not cover that lateral femorocutaneous nerve and spares the LFCN. So we can very easily supplement it with a lateral femorocutaneous nerve block. And just to give you an idea, that red indicates the dermatomal distribution of the lateral femorocutaneous nerve. It's great coverage for things like posterior lateral incisions of the hip. It's different indications for lateral femorocutaneous injections or blocks include hip arthroplasties in the setting of a PENG block. Obviously, if you do a fascial block or a lumbar plexus block, you would cover it, so you don't need to supplement it with that. Any above the knee amputations, which is a great adjunct to a femoral, a subgluteal sciatic, and the obturator. Skin graft harvesting if they're going to take something on the lateral side of the leg. And then for diagnostic and treatment purposes of neuralgia paresthetica, if they start to have increased pressure right in that canal and you want to diagnose it or treat it, it's a great injection. And the way that would work, it's a very technically simple block to do. It's very superficial. Lateral is over here, medial's here. You can see this nice little fat pad. Deep to that is the tensor fasciolata, and then medial to that is the sartorius. So usually when we do the scanning session, we'll show you how to find it. But my approach is way over here would be the femoral artery and vein. As we scan out laterally, the sartorius terminates here, and then right at that termination point, superficially, you see a nice little fat pad. And then right within that fat pad, you see this hyperechoic little berry or nubbin, and that would be your target. And so we're going to break out, and we're going to hand over the show to Dr. Burnett here, and we're going to do some live scanning. Yeah, sure. Yeah. All right. So Dr. Burnett's palpating for ASIS right now to get that suprainguinal fascial. And you can see on the screen the position of his probe is sagittal, just medial to the ASIS. And we'll show that one more time. Is it not? right, we are going to try to reboot. But does anyone have any questions so far about the material before we go into the live scanning about any of those blocks? Okay, great. Why don't we move on then to the next section, and then we'll scan both sessions right after this next cohort of blocks here. So moving on a little more distally, we have the femoral block, and the femoral nerve. It branches to multiple joints, including the hip and knee, as well as that anterior thigh. And then it gives off that sensory branch, the saphenous nerve, that then covers the medial aspect of the leg all the way down to the medial malleolus of your ankle. Back in the day, we were doing landmark-based technique where we would palpate the femoral artery and then just go 1 centimeter lateral to that palpation. And then you would feel a double pop. And the two pops that you were going through were the fascia lata and the fascia iliaca. I still think it's a great technique. But now that we have the ultrasound, I kind of like to see where I'm going. Just to give you an idea of what it would look like with a nerve stim in the past. So same idea with the landmark technique, but as you're going in with the nerve stim, we would be looking for that nice quadricep twitching, as well as that what we call the patellar snap, with the nerve stem being around 0.2 to 0.5 milliamps, which is that sweet spot to make sure that you're not too far or too close in a fascicle. And then we would inject there. In terms of the anatomy of the femoral nerve, it tends to lie just on the lateral side of that femoral artery, like we just discussed before. The two pop technique, again, would be just coming 1 centimeter over laterally to the femoral artery, popping through that fascia lata and then the fascia iliaca, and then you were probably somewhere around here when you saw that quadricep twitching. And the other thing to note is that the femoral nerve kind of looks like this linguine-shaped instead of a spaghetti-shaped nerve. Tends to be kind of sandwiched between that fascia iliaca and the iliopsoas muscles. The other thing I wanted to point out is that a lot of times something like this looks like a nerve structure, but that's just what we call post-cystic enhancement. It's an ultrasound artifact. And what's happening there is you have your piezoelectric crystals from your ultrasound on top here, sending down beams, hitting this part of the endothelium of the wall, bouncing back to your piezoelectric crystals while you have other sound waves coming down, hitting this part of the endothelial wall, coming back rapidly to the piezoelectric crystals. And because you have that corroborated response of two bounce backs very quickly, something distal to that, the ultrasound is reading as more electrical energy responding back to those piezoelectric crystals. You get more mechanical shake of that piezoelectric crystals, which then translates into a hyperechoic image. So just distal to any cystic structure, you would see something like that, which actually is not the femoral nerve. So just keep that in mind. It tends to be more lateral. Do we have it fixed now? Okay. So we'll kind of pop back to the scanning session, and then we will resume the femoral nerve block. Thanks for bearing with us. Okay.
So like you said, we're going to feel for ASIS.
It's feeling for ASIS, and you can see.
Is ASIS. Mm-hmm.
So ASIS was that hyperechoic little dome that you saw right there. And then I'm going to slide just medial to that until you see this bone down here. That's the anterior inferior iliac spine, the IIS. Right about this level, you're going to see this really fat iliopsoas muscle. And then that little, remember, dress to impress block, right? So this is the bow tie. So here is the pinch, the neck of the bow tie. Here is one leaf of the bow tie, and then the other leaf of the bow tie. I take
Right is sartorius.
Sartorius?
Is your internal oblique, and we see the circumflex artery.
Let me see it. There. So that's the deep circumflex of the iliac artery, which lies between the abdominal muscles and the iliopsoas muscle. So that tells me that this is the perfect plane for a suprainguinal fascia iliaca block. Yeah.
since I have a linear probe stick.
Now we're going to go to the lateral femorocutaneous.
So there's our femoral artery. We're going to scan laterally. There's my sartorius starting to come into view. That's the fat pad right there.
The sartorius terminates right around there. Here's tensor fascia lata. And then there's a little fat pad right there. And you can see that little berry. You can see how superficial this is. This is, about half a centimeter. So it's, we go in, remember each one of those marks on your echogenic needle or peripheral nerve block needles is only 1 centimeter. So not even getting into that entire mark will achieve a blockade of that lateral femorocutaneous nerve there.
Let me just switch the probes.
Anyone in a burn unit? Anyone doing like skin grafting of the lateral side of it's an amazing block for that. These patients are writhing in 10 out of 10 pain after that graft, and you just pop in that block 5 cc's and they fall asleep.
We're going to start.
So this is the Peng block. So Dr. Burnett switched over to a curvy linear probe. And you can see,
As superficial as I can go.
okay, so a nice little trough here, okay? That's the IIS we talked about. There's the iliopubic eminence somewhere over here. And that hyperechoic structure here is the psoas tendon. And this is all iliacus muscle here.
And now if I went a little too down, you'd start to see a bony structure that's the head of the figure. So that tells me that I'm too distal in the leg. If I come back up, now I have that continuous line of bone. That's the iliopubic or the AIIS and the iliopubic eminence.
Are you able to show the femoral nerve or femoral artery and vein somewhere up
See it
here?
on the screen better.
Okay. Yeah, so just keep that in mind. When you have your femoral vessels over here, there we go. The femoral nerve lies somewhere up here. So the point of, using saline when I first hydrodissect down is if you're hydrodissecting with local anesthetic, too much of that in the iliopsoas muscle can extravasate to the femoral nerve itself and cause quad weakness.
Can you show us where to say
Yeah. Can you?
The what?
Yeah. Can you go back down to the probe to show us, please?
Her ASIS is right here where my fingers are. So ASIS is here.
So,
Oh, I got my probe for
yep.
just a second.
Umbilicus.
And I'm basically in the same spot where I would be for a femoral block or a femoral arterial line or femoral central line. And then I just come a little bit lateral and then fan. You can see how I can see all of the bone down to the target location with the iliopubic eminence. And then if I scan too far down, that's when I start getting into the leg and I get the head of the femur.
So when in doubt, scan for the femoral artery first, as if you're going to do a femoral nerve block, right? And then because you can see we're right in that same visual field. Then drop the depth, because when you're doing a femoral block, you're really just concerned about something superficial way up here. If you're seeing that, then drop the depth even further until you drop down to this pelvic brim. And that's the target for the Peng block. So just kind of start with that femoral artery first.
And one of the main things with this is we're using a curvilinear probe, so we get a very wide field of view. But you can see that the depth is not that. We don't really need the depth that a curvilinear probe might provide.
And if anyone is practicing without a curvilinear probe, it's not available to you in your practice, you can easily do this with a linear probe as well. I don't know if can you show them what that would look like? This is a clear image. Femoral artery is way over here. Femoral artery, nerve is somewhere along here. Here's fascia iliaca. You can see that was our femoral view. If your screen is only cut to here, drop your depth quite a bit until you see this bony structure. And you can see a very clear hyperechoic psoas tendon, iliopsoas muscle. Here's the trough. Here's the AIIS. The iliopubic eminence is off of the screen here. So the needle trajectory would come straight across through that iliacus muscle. I usually scythe and kind of skim this trough here and then watch the muscle and the tendon lift off the bone. Yeah, and then we'll quickly go over the femoral nerve as well. So we can drop the depth a little bit.
So you can see iliacus is this hypoechoic muscle. What we're looking for is the fascia that's covering that. It's going to cover the femoral nerve as well. So if you look at the top fascial plane above the iliacus muscle, you start to see the wedge shape of the femoral nerve just under it.
And
Not always that close to the femoral artery, like
yeah.
it looks like in here, but for her it is. That's okay.
And again, look, there's that post-cystic enhancement, not the nerve. Usually tends to be right on the lateral edge, linguine shaped, not spaghetti concentric. All right, any questions about those? Yes, sir.
Can we go back to the fascia iliaca block and show where the needle should be?
Yeah. We're going to go back to the suprainguinal fascia iliaca, and we're going to demonstrate where the needle stick should be. So if you could point.
In a high BMI patient, like including the suprainguinal fascia iliaca is amenable of you have like a BMI cutoff or like do you always prefer suprainguinal or when will you go to infrainguinal?
Yeah, so the question, that's a great question. So does the BMI affect the technical challenges of doing a suprainguinal fascial block versus doing an infrainguinal or the classic fascial block? If you are, the bony structures and cystic structures, right, artery, vein, they tend to be pretty easy to find regardless of body habitus. And so for this, even the suprainguinal, if I could palpate that ASIS first and then just step off of it just medially to find that AIIS, I haven't had a problem. I mean, I'm glad you brought this up because literally last week we had a hip fracture patient with a BMI of 80 and we did a suprainguinal. And you could, I mean, yeah, we had to drop the depth, but I didn't need the curvilinear probe. I applied a lot of pressure and I was able to actually see that AIIS. And so if you could see that, then from there, you can see some of the other structures that are going to be aligned with that AIS, which is the pinch of that bow tie. But that's not to say, like, if you're having a hard time finding that and you think that it would be easier for the patient to hold their pannus up and then for you to just pop it right in that classic infrainguinal approach, that's a lot better than not doing a block. So whatever you feel comfortable doing, I would say as long as that some local gets under a fascia iliaca, whether it's supra or infrainguinal, you're doing them a good service. Okay, so the question was, where do we stick the needle? If you could scan down to the probe for a second.
Yeah. So there we see AIIS. We see iliacus covering it. On the left side of the screen, we see the internal oblique. So our needle.
So yeah, so first, needle approach would be caudal to cranial this way. Okay, so injection on the caudal side, and then if we can go back up to the ultrasound.
So our needle would be coming in from the caudal side, popping into this plane right here, and looking for spread under that artery, under the circumflex artery.
Yeah, it's sagittal. Now, one tip to make the planes a little clearer, sometimes the cranial part of the transducer, if you aim it just toward the umbilicus ever so slightly, you do get a clearer view. But as long as you're really able to identify this AIIS, that pinch is right above that level.
And it does look a little bit better on my screen than it does on the screen.
Yeah.
So it may just depend on your ultrasound.
Was there another question back there? Okay. All right. Okay. All right. So we talked about That's right. All right. So we talked about yeah, we have to make sure that our models are comfortable and not falling off of these inflatable beds here. So we talked about the femoral nerve, obviously motor blockade, right? Because the femoral nerve, as we know, comes off of L2 at L4. It arborizes into all the different branches that innervate all your quad muscles, including the rectus femoris, the vastus lateralis, intermedius, and medialis. So then the question becomes, well, if we're trying to do some of these blocks that are motor sparing, is there anything we can do to scan a little more distally to catch some of the innervations after they've arborized and terminated into some of those quad muscles? And so that's where the adductor canal block comes into play. The adductor canal is roofed over by the sartorius muscle, laterally by the vastus medialis muscle, and then posterior medially by the adductor longus or the magnus, depending on where you are on that thigh. The adductor canal block emerged as an alternative to the femoral nerve block, especially as we were thinking about more motor sparing techniques in the setting of total knee arthroplasties. It's also a great block for ligamentous injury and repair, especially if we're trying to get any of the cruciate ligaments. And it's a great supplement to the sciatic nerve, especially if we're doing foot and ankle procedures or below the knee amputations to predominantly get that saphenous nerve. Again, it targets that saphenous nerve, so you shouldn't see any muscle twitching if you're very close to the actual superficial femoral artery, because the saphenous nerve tends to lie right in that periarterial region. But within this plane here between the sartorius and the vastus medialis, a little more laterally, you should see the nerve to vastus medialis. And so if you do see some twitching, you may be a little too lateral. So this is a video showing the sartorius muscle up here, the superficial femoral artery. Here's the saphenous here, and then the nerve to vastus lies right here, and you'll see it a little clearer after the local anesthetic comes into play here. So the needle trajectory is going to be right in between that saphenous and that nerve to vastus medialis. So you're popping under the saphenous nerve, getting in the adductor canal here, popping through one more membrane called the vastoadductor membrane to get that saphenous, but you do have some retrograde extravasation of local anesthetic to get you that nerve to vastus medialis as well. If I'm doing just a foot and ankle procedure, I don't need to worry about that. I just need the saphenous nerve. But if I'm doing a total knee arthroplasty, then targeting both is very important. So the terminology that you may hear is, are we doing a femoral triangle block versus an adductor canal block? And in terms of the nomenclature, the femoral triangle block, I presume that most of us are doing a femoral triangle block because we tend to go up a little higher. You do run the risk of getting some more of the terminal branches of the quadriceps muscles, slightly more motor weakness. So we try to get down to the adductor canal as much as possible. But to delineate the difference between these two sites, the femoral triangle and the adductor canal, it's where the medial border of the sartorius and the adductor longus start to cross over each other. And so on ultrasound, it kind of looks like this humpback whale. Here's the eye, here's the mouth. The sartorius on the medial side, that medial edge of that and the adductor longus perfectly align with each other. It's at this point where you see the apex of the femoral triangle, and then anything distal to this point would be the adductor canal. By staying within the adductor canal, you run a lower risk of getting some of that motor innervation and quad weakness postoperatively. And this is exactly what I just talked about. There are many studies that show either equivalence or non-inferiority of the adductor canal block over the femoral nerve block in the setting of total knee arthroplasty while sparing that motor component so that they can participate in immediate physical therapy. But when you think about doing a block, is the adductor canal block a complete block? And we know that we're sparing a lot of nerves by just doing the adductor canal block instead of the femoral. And the question really becomes, do we need a complete block? And the short answer is it really doesn't have to be a complete block, because by integrating multimodal analgesic protocols, as defined by the American Society of Anesthesiologists practice guidelines, using 2 or more analgesic multimodals in the setting with different mechanisms of action in the setting of an adductor canal block provides superior analgesia and limits the side effects of that quadriceps weakness. So, when we think about doing a femoral block, in my mind, I'm a wimp. So if I got a total knee, I would want a femoral nerve block because I don't want to feel a lot of that. But at the same time, that PT is so important for long-term outcomes. And so this is a great way to give you that motor span block while taking multimodals as well. And then plenty of studies, again, showing that superior functional outcomes while preserving the quad function as well. So we've been really implementing the adductor canal block instead of the femoral block in the setting of total knee arthroplasties. Just a word of caution that there is a fall risk whether you do a block or not, because when you think about the block itself, you're not only blocking the motor and the sensory, but you're also blocking some proprioception. So it really is crucial to maintain the balance while the patient is mobilizing. And then even if you don't do a block, there's a potential quad weakness and compromise just from the surgical insult while going through the quadriceps muscle itself. So in general, whether you do a block or not, my advice is, fall prevention programs, make sure you have a multidisciplinary team and strong communication with the surgical team as well as your physical therapist to make sure that they're set up properly to avoid even a 1.2% incidence, which should be a never incident. We'll very briefly talk about the obturator nerve. Pretty low yield block, but comes off of L2 to L4. It's very medial. There are 2 branches that sit that anteriorly and posteriorly between the adductor longus and brevis, between the adductor brevis and magnus. It has very variable cutaneous sensory distributions on the medial thigh. And so usually when I do it, we assess the block by checking for adductor strength instead of skin sensation. It's a great addition for things like above the knee amputation, again, because you do need to not only get that femoral and sciatic, but that lateral femoral cutaneous and the obturator to get the medial part of the thigh. And what that would look like on ultrasound is as we scan right in that groin line, you have this big muscle here called the pectineus, and then right at the convergence of the pectineus, you have the adductor longus, adductor brevis, and adductor magnus. And right in this, it's kind of, some people describe it as an eagle's beak. The pectineus is the face of the eagle. Here's the beak. Right at this juncture, you would see the anterior branch of the obturator, and then between the brevis and magnus, you would see the posterior branch of the obturator. So we're going to go ahead. We scanned the femoral already, so we're going to go down and scan the adductor canal and then the obturator as well. And spit out any questions as we're getting set up if you all have any.
I think we're gonna have to inflate again in just a second. All right, but generally what we do is we kind of have them frog leg. So bend the knee, let the knee like flop out laterally. That just makes it a little bit easier because your target's a little bit more up and down towards the ceiling. All right, so bone is always going to be easy to find, right? So we see femur there, and we can move medially until we start to see the sartorius. You can see that the femoral vessel is just under. And as we track up, the relationship between the sartorius and the femoral artery changes, because remember the sartorius is moving from the lateral aspect of up at the ASIS to the medial aspect of the medial patellaris. So in terms of where I would block, I generally go more or less where we're kind of in the belly of the muscle. We would be coming in from the right side of the screen. So we can look and see arthroplastis.
Possibly that, yeah. But the nerve to vastus tends to lie lateral to, the saphenous way over here, and it lies underneath the sartorius muscle itself. So in terms of approach of your needle, you can either come down like this and pop right underneath sartorius and staying away from any hyperechoic structures that might resemble the nerve to vastus, or you can come out very lateral, pop under sartorius way on the lateral side, and as you're advancing, hydrodissect and create a pocket of local as you advance over the nerve to vastus and the sartorius. Questions about that? And again, if you're only doing foot and ankle procedures, no need to target that. I just come straight down and go periarterial to get the saphenous nerve. All right, for the sake of time, I'm actually going to move forward. If anyone wants to see the obturator at the end, I think it's such a low yield block that for the sake of time, I'm going to skip that. But if you want to come up, I'm not going to offer my obturator, but we'll see if we can scan her afterward. Okay, so we just went over the lumbar plexus, right? So let's shift gears a little bit and go to the sacral plexus to get the sciatic nerve. The sciatic nerve comes off of L4 to S3, provides sensory innervation to the posterior knee, the lower leg, except for that medial portion, that saphenous nerve. So my favorite true or false question to ask my residents and fellows is true or false, all motor innervation below the level of the knee is innervated by the sciatic nerve. And the answer is true, because I said motor, right? There's only one sensory branch below the level of the knee that we're not covering with the sciatic nerve, and that's that saphenous branch that we went over that comes off of the femoral nerve. It's a great nerve to block anywhere along that posterior thigh. It's great for BKAs, AKAs, ligamental work, as well as TKAs back in the day, but we no longer use this again because we want motor sparing techniques. And then really great for foot and ankle surgeries. The transgluteal or the Labat approach was first described, where you draw a line between the greater trochanter, and the PSIS, the posterior superior iliac spine, and then cut the line here in half. So the midway point between this line, draw a line down between the greater trochanter and the sacral hiatus. And right at this point is where you would catch a transgluteal sciatic nerve. And on ultrasound, you would see that ischial bone is a nice safety point. So a lot of times we're not really getting any deeper into the pelvic floor, so that helps. And then you would see on the ultrasound the gluteus maximus and then the sciatic nerve right there. The subgluteal approach is also a very safe approach. You can palpate the groove between the greater trochanter and the ischial tuberosity. By coming down a little distally than the transgluteal, you may spare that posterior femoral cutaneous nerve in about 30 to 50%. And then using nerve stimulator here is helpful. And then it's a great spot for you to thread a little catheter there if you need it for like a above the knee amputation. And this is what it would look like on ultrasound, and we'll show you that in a second, where you would see the ischial tuberosity. That's the butt bone that we sit on, the greater trochanter here, and then the two muscles to keep in mind are the gluteus maximus, the quadratus femoris, and within this little hammock lies your sciatic nerve. Scanning down even further to the popliteal fossa. This is great, again, for foot and ankle procedures. The position of this, I think a lot of us in this room are using this block already, but you can either have them supine with a bump, you can have them lateral decubitus, or prone. I think the prone approach is very helpful in morbidly obese patients. You're trying to let gravity work for you. Just a technique that really helps if you're using any of these needles with marks on them, whether it's an epidural needle, TUI, or an echogenic needle with centimeter markings. I usually just mark, when I find the image, you see that it's about 3 centimeters on the ultrasound. So I'm trying to come in with a very flat trajectory of the needle so that the needle is nice and perpendicular to the sound waves coming off of the ultrasound. And so I'll use these marks on the needle to measure if this is 3 centimeters. If this is 3 centimeters from the surface of the skin based on the ultrasound, and this is my target, then I'm going to measure 3 centimeters up with these markings. And then X marks the spot, and then you can come in very straight across the screen to really visualize your needle. And that tends to help quite a bit with finding and optimizing the anisotropy of your needle as you do this block. Again, that causes a lot of motor weakness. So in the setting of total knee replacements, that's a block that we no longer do. So then we move on to what's called the IPAC, the interspace between the popliteal artery and the capsule, the posterior capsule of the knee, first described in 2012. It selectively gets those terminal genicular branches that come off the sciatic nerve, that popliteal plexus that lies just deep to that popliteal artery. This is a cadaveric image showing staining, and you can see that when you do the IPAC block, it really gets that posterior capsule while sparing the actual common femoral or common fibular nerve and the posterior tibial nerve. It's a great motor sparing technique. There are different approaches. You can either do the medial approach where the knee is fanned out this way, frog-legged out, and you can see the popliteal artery way down here and the femur here, and you can come straight down right along that posterior capsule of the knee. Or this was what was first described, the lateral approach. You can see the popliteal artery way up here. Here's the metaphysis of the femur, and then this is the target where we would go to get the genicular nerves that come off of the sciatic. And so this is a video showing the lateral approach. Here's the popliteal artery. Here's a nice flat metaphysis of the femur. If you go a little too distally, you might see condyles here, which tells me you're a little too far into the popliteal fossa. And then you're just going to go straight across into this posterior capsule and inject as you come out. If I were to be hypercritical about this specific block, I would have started maybe another centimeter lower away from the transducer so you can see a nice flat trajectory of that needle to really avoid the sciatic nerve way up here. Evidence of IPAC blocks may improve post-op pain scores and opioid consumption reduction. Some studies demonstrate a decreased length of hospital stay, post-op opioid consumption, decreased median pain scores, as well as increased direct home discharge instead of going to a skilled nursing facility. This narrative looked at or reviewed 35 articles, and there were no definitive recommendations in terms of using the IPAC block due to the heterogeneity of the data and just a limited evidence base. This systematic review and meta-analysis published in 2021 showed that the addition of the IPAC to an adductor canal block in the setting of periarticular local infiltration by the surgeon does not improve any post-TKA analgesic outcomes. So if your surgeon is locally infiltrating, a lot of times we won't do this IPAC block, but if at any point you're watching the surgeon do the infiltration and you're not very confident in that block, or they're just blocking, fat pads or what have you, then have a discussion with them and say, look, I can visualize my local in that posterior capsule, so it might be worthwhile for us to add that IPAC block. And then just scanning even distally, getting to the level of the ankle. You can do a beautiful ankle block. The 5 nerves we all know, but that posterior tibial nerve we'll show you on the ultrasound is a very elegant way to get that posterior tibial nerve. The other 4 I just do landmark based, and I'm happy to show you guys that if you come up after, just for the sake of time. But we'll go ahead and jump into the live scan with these four blocks. The brand of this air mattress is Intex, in case you want to stay away from it. Yeah. Man, I think I can make one better than this. All right, so you can see she's in sloppy lateral decubitus. We're scanning just underneath the gluteus maximus. This is the subgluteal approach. just underneath the gluteus maximus, the two bony structures again we're looking for are the greater trochanter and the short tuberosity. Here's the gluteus maximus way up here, quadratus femoris here, and right within this hammock, that's where the sciatic nerve lies. So this is the subgluteal approach to the sciatic nerve block. There's a great view of the sciatic nerve block. So in terms of the needle approach, we're coming in lateral to medial like this, and then you pop. Treat it like a fascial plane block where you're going between two muscles, right? So the gluteus maximus, the quadratus femoris. Never just skewer through that nerve. Either go on one side or the other of the local or of the nerve, and then inject that local so that you see spread either going over or under the nerve itself. Yeah, I typically use stem with this because a lot. I mean, her anatomy looks great, but there are times when you're scanning and you see 4 different hypoechoic structures, and you're wondering which one's nerve, and so the stem becomes very helpful for this block. That's a great question. Anyone else? Okay, so we're gonna continue to scan distally down that posterior thigh to get the popliteal approach. Oh yeah. So we'll start with the IPAC since we already have the curvy linear probe. The probe is right in that popliteal fossa first.
So you can see there's condyles. So you see both bony structures, the medial and lateral condyle there. You can see the pulsatility of the popliteal artery. Right now I'm really tilting my probe into the knee. Now I'm going to fan up towards the shaft of the femur. It starts to flatten out a bit.
You can still see the pulsating popliteal artery. So if you ever see those humps, those condyles, you're a little too distal into that popliteal fossa. So scan a little more cranially until you see that flattening of that femoral shaft.
And I usually scan up and down and just see if there's a little bit, an area with a little bit more space to maneuver my needle, because she's got a little bit of a tight window between the artery and the bone.
So this would be our window right here. Infiltration between the popliteal artery and the posterior capsule of the knee, IPAC. Questions about that? Great motor sparing technique. Yes?
With the lateral approach, what about common pattern?
Yeah, that's yeah, and you should always find that too. That's a great point. So the question was, with doing a lateral approach, should we be looking for that sciatic nerve? Yeah. So just so that you know what to avoid.
So tibial nerve is right here, right on top of the artery. And if I start to scan up, we may see cranial comes together there. So if you can visualize it, that's ideal to know where it's at before you stick with the IPAC. But you can see both nerves are up high, and there they come together, and there they separate. Together, separate. So having an idea where they are.
So do you think that the medial is more safer than the lateral approach, or in terms of avoiding common phenomena is not?
I mean, I think as long as you can visualize where they are and you're injecting into the plane close or not, you should be able to avoid it. I do tend to do the medial approach more often, like medial approach with the needle.
Yeah, and then more reason to make sure. Remember the 3 centimeter marking that I showed you for the popliteal sciatic nerve. Same principle here with the IPAC. Start further away from your transducer so that your needle comes in a very flat trajectory, and that way you avoid having to come from a very surface level and potentially get that perineal nerve. Okay, and then we'll shift gears to the popliteal sciatic nerve block.
Okay, and just as I visualize the 2 nerves in the popliteal fossa with the curvilinear probe, I'm now going to switch to the linear probe. Put it in basically the same exact position, and tell that there's nerve structure right on top. This is where fanning the probe back and forth and really getting the nerve to highlight itself there is helpful. So typically the nerve that's going to be right on top of the artery is going to be your tibial nerve, and And then to the lateral aspect, which is the left side of the screen, we're going to look for the common perineal to come in and join it. They're coming together, and they're together.
Common perineal, posterior tibial.
And then they're starting to split. So together, and now they're starting to split.
And the variability in terms of distance away from popliteal fossa is quite apparent in every patient. So roughly 7 to 9 centimeters cranially to the popliteal fossa is where you'll see the convergence of that posterior tibial and the common fibular come together. Yeah. All right. Do you want to do the posterior tibial nerve at the ankle?
Yeah.
Oh.
We got you.
Again, intact cystidae.
We're going to put this down.
Go back to, perfect. So we're just posterior lateral to the medial malleolus. If we could go up to the screen now. Yeah, and you can see the medial malleolus was right down here. Yeah, there it is, yeah. And then posterior lateral to it, you can see the posterior tibial artery pulsating right there. And then just adjacent to it, this is a neurovascular plexus here, and that's where that posterior tibial nerve lies.
If I scan up towards the leg, it becomes starting to become a little bit more apparent.
Yeah, that's great. So 3 to 5 cc's is all you need, and you have complete plantar foot anesthesia there. Okay. And then we're running out of time, but I'll quickly go over the genicular nerves. They come off of the posterior tibial nerve. You got their supermedial, superolateral, and your inframedial. The infralateral we try to avoid because it's pretty close to that perineal nerve. And so in terms of the ultrasound scanning, it's a very simple block to do in the sense that you have a nice bony backstop where your transducer is in a sagittal position like this, just above the patella or below the patella for the inferior inframedial genicular nerve. And then you're going to come down and hit the bone right as the shaft of the femur starts to wind up toward the condyle. And 5 cc's right there, 5 cc's there, and 5 cc's there. That's a trick. And again, these are the different approaches to the 3 genicular blocks. Do they work? The group from Duke did this study, looked at 40 patients who either got a sham block or these genicular blocks. It's actually pretty profound with this data. In the first 24 hours, there was an opioid consumption of 58 versus 23, and then in 48 hours, 98 in the sham versus only 50 in the patients who received genicular blocks. Take that for what you will. Is anyone doing genicular blocks routinely for TKAs? Okay, just a handful. I save them for rescues, and sometimes they work really well in the back. The challenge is the wrap. So you do have to take all that down if you're going to do it. I save it for if they're in excruciating pain, then we'll go ahead and do those, and it works really well as a nice rescue if they do need it. And then very quickly, the infrapatellar branch off the saphenous nerve, when we do the adductor canal, that covers the inferior third of that huge incision. When you look at a total knee arthroplasty, the inferior third of it is covered by that infrapatellar branch that comes off of the saphenous, but that superior 2/3 of that incision is covered by this anterior femoral cutaneous nerve. And so when you think about the intermediate and the medial femoral cutaneous nerves, it's a very easy block to do because it's right in the setting of the adductor canal. This is the sartorius right here. Here's the SFA. This would be the approach to the adductor canal. Then I come back, and right in the sub-Q window, you see these little berries. Those are those anterior femoral cutaneous nerves, and we do a little skin wheel here, about 5 to 10 cc's, and that gets you that nice anterior femoral cutaneous view. And that is how we'll end it. I think for the sake of time, though, if anyone wants to come up and see that, we can certainly do it. But I think because we were taking questions throughout, I think we kind of ran out of time. But does anyone have any pressing questions based on what we just went over? Yeah.
Sure that you get the nerve vagus medialis. Would you use a nerve stimulator for that?
Yeah, and we typically do, and the question is, do you typically use a nerve stimulator when approaching the nerve to vastus medialis for an adductor canal block? And the answer is yes, it does help. If you don't have access to one, I usually take that very lateral approach to get very lateral to that sartorius, just to really stay away from anything that resembles the nerve to vastus. And then as I'm traveling underneath the sartorius, start injecting and hydrodissecting that plane to really minimize the risk of mechanical nerve injury with a needle. All right, yes. Usually to treat it, yeah. I've never seen it cause it, yeah. Yeah, yeah, exactly. Which approach? With this, yeah. Other than actual neuropraxia or postoperative neurologic symptoms, just from the block itself, from the nerve block itself, and then vascular injury. Those are the. Yeah, so the popliteal, certainly the subgluteal, transgluteal, I would treat that more like a deep block if you're, especially if you're not very savvy with ultrasound. They are guidelines, so also risk benefit. You know, I've had really sick and anticoagulated patients who are getting above the knee amputations, and it was decided we should really avoid general anesthesia on these patients. And so using the ultrasound, really turning on Doppler, ensuring that we're really not getting any of those collaterals. You can do it that way as well. But to adhere to the neuraxial guidelines for deep blocks like that subgluteal sciatic. Yeah, of course.